Good afternoon, everyone. Thank you for joining our session this afternoon. Today, we have the honor of talking with Rush University, and we're going to talk about efficiency gained in a very difficult place to gain any kind of efficiency, and that's the emergency department. I can tell you that because I'm a practicing emergency physician. My name is Dr. Donald Koziak. I'm the Chief Medical Officer for Leidos. Leidos is a very interesting company that focuses largely on the federal government customer. We've been in practice for more than 50 years, serving the government in things from defense to intelligence to healthcare. One of the things we're most known for recently is the electronic health record implementation across the federal government space, but we do all sorts of life sciences work, command and control work, and the like. We're going to get into why Rush and Leidos partnered to help with streamlining during this discussion. So again, thank you for choosing to be with us today. I'm going to turn it over to my co-presenter, Dr. Paul Casey, for his introductions.
Thanks, Don. Appreciate it. My name is Paul Casey. I'm the Chief Medical Officer here at Rush University Medical Center and also the interim president for the faculty practice group. Just a little bit about Rush itself. So Rush University Medical Center is located in Chicago, Illinois. Interestingly, the charter for the university was 3 days before the founding of the city. So we've been here a long time, and really we have built our brand around quality and safety. And that's what I think what you hear a little bit about in this work. But we're an honor roll hospital, CMS 5 stars, Leapfrog, grade A, and more recently recognized as #2 in the country for Vizion's quality and accountability study as well. So I think you're going to hear a lot about our journey, our quality journey, and specifically around ED operations. I'll turn it back to you, Don.
Excellent. Hey, so being two emergency doctors, we have to have at least one emergency department story. So I know you were working recently clinically. What was one of the coolest things that you got to see on your last shift?
Oh boy. I'll tell you, I don't know that this is the coolest thing, but I'll tell you what was a relief is having been through the last couple of years in the emergency department and the acuity that the pandemic brought us and really, the COVID patients themselves. It's almost nice to see, we've seen this real return of some high acuity business, but mixed in there, it was a relief for me to see a young man that came in with some abdominal pain after eating a bag of flaming hot Cheetos. That really, to me, was the bookend on the pandemic that he felt comfortable coming back to the ED. So that's the memory.
And the best part is he didn't have to wait long in the waiting room because by then the Cheetos would have made him feel better.
That's right.
Like they've been up in your left without being seen number. So exactly why the efficiency we're going to talk about today is so important, so that you can see a man who has tummy pain after eating Cheetos. I agree. My last clinical shift, very similar. There's still some COVID mingled in there, and we're seeing some really sick people that have put off some care for a little while. But it is nice to see some of those things that used to drive you crazy, the non-urgent visits. But it's glad that they're back because that means they're feeling comfortable about venturing out.
That's it.
So let's talk about. We're going to do a little bit of a fireside chat. I'm gonna pepper you with some questions. I'll try to add some color commentary where I can. But really, let's talk about why would you ever try to streamline the chaos that is the emergency department? Why was that the place that Rush said, you know what, we're going to start here and get it organized?
Yeah, it's a great question. I think, it's like all things, right? When you're working in that environment and you see the emergency department is inherently unpredictable in many ways. So you really want to be able to bring some thought around how to control the things that we're able to control within the emergency department. And what used to frustrate me years ago was that there was no real order, there was no standard operations, there was no way to measure how we were doing day to day. And you could tell, what felt like a good day or felt like a bad day, but you were never quite certain, what things were going. And there was nothing more frustrating as I moved on and started looking more through kind of operational metrics and things like that, to a week in arrears be looking back and saying, geez, last Tuesday, looked horrific. So it led us on back years ago, started this emergency department innovations team to really bring staff into the room and start really thoughtfully going through, let's take the front end process. Let's take from when someone walks in our door till we get them in a room, let's beat it up. and try to figure out exactly where, we can take some non-value added steps out of that from the patient's perspective and really streamline. And then we went through, each really with this team over a period of about a year, each different segment of the patient journey through the emergency department. And we were all feeling really great about ourselves. I think that, we had put in place these various improvements. But what inevitably happens is you improve one area, you take your attention off it, and then next you look and you backslid, unless you really put hardwired some operational tools in, inevitably you see this backsliding. So there's this journey of, improvement, you're feeling good about yourself. A month later, you look back and you say, geez, we just didn't sustain it. So it's what really led us to think about what a more sustainable and hardwired solution would be, and brought us down the road of a larger kind of value stream transformation around emergency department operations.
Well, and I have to tell you, because I know how it ends, right? You came up with some really interesting metrics that just aren't in the usual vocabulary for how you measure emergency department throughput, like last to pull time and all sorts of things that just aren't standard. So when you started the journey, what kind of metrics were you looking at, and where were you falling below what you would consider your standard, if you will?
Yeah, that's a great question. I think when I referenced the frustration around seeing data in arrears and metrics in arrears, what always used to drive me a little crazy was when we look back and see arrival to discharge, or, which is a CMS measure at one point. And that really doesn't tell you a whole lot about the operations in the room, right? So you look back and you see, arrival to discharge last week, we were an hour over our goal. And it absolutely is uninformative in every way as to like what were actually the challenges in terms of people moving through. So did a lot of reading and really started looking at, more how these things are managed, in industrial engineering and things like that. Even these days, you go to Starbucks and you see that, they have very discrete steps. So that's what we did for emergency department. We really broke down into very discrete steps and broke up into different operational units, so we could really measure things just like you referenced. What's the last time we pulled a patient back? How many people are waiting to get into that particular area, operational unit or flow cell? What's the amount of time people have been in there, and what are the barriers within that? So I think we'll see a little more of that. But as we're looking at here, really the important thing is, as I said, there's a lot of things we can't control within the emergency department. Unlike other operational units, you can't always control the volume coming in the front door, nor how you're getting patients out into the hospital, especially with ED boarding that many institutions struggle with. So we really tried to look at what do we have control of, and that's processes. That's the queue, the waiting, the patient paths, and really how we can manage those resources most efficiently. That led us to some of those metrics.
Yeah, perfect. And probably like every hospital and health system, you did the lean journey, right? And I love these slides that you have on the board and the process. And what I think is unique about what you've done is that you really did carry through those changes that you had, and you operationalize them. A lot of people do the journey and then they find it's really hard to change the way they're doing stuff. And so they stop there, or they change a few things, or they play, as you described, the whack-a-mole, like we focus here, so we whacked it down, then another one pops up. So tell me a little bit about the good and the bad of that lean journey, and what you found was easy to fix and what was really hard to fix, and then what was missing that made you go elsewhere.
Sure, absolutely. To start with maybe what was hard about it, I think everyone has to be very realistic that this takes time. And I would say, from the time this work was done several years ago till now, I mean, there's continued time and effort put into really making sure that this continues to be successful in many ways. And really the design phase, I tell people I spent about 60 hours in one academic year in a conference room with our teams really working through this. So that there's certainly a time investment that you got to put in, but I think what we quickly realized, now and now I can say years later, is that investment is worth every ounce of sweat that goes into it when you look at some of the results and outcomes and just the operational cadence of the team. So what you see here was actually some of our earliest work, which is really, it's nothing fancy. It's certainly not reaching to create, digital tools as we eventually landed on. It was really, pen and paper, getting a team together, creating this whole value stream from the very start to the end, coming up with some operational principles on how we were going to manage teams and how patients were going to flow through the department. Doing a lot of work around redesigning. We were in a relatively new footprint, but we really had to rethink how we were using different areas and different rooms. And you can see that on the architectural plan on the right-hand side. But there's constant experimentation in this. The nice thing about building in these tools and building in this cadence and really training a group of individuals to be experts on this is that you never are at a final product. You're constantly iterating on what can we do better, how can we improve day by day, week by week, and month by month. And that all starts really with the pens and papers and understanding where you are and where you want to go.
Yeah, and we talked about metrics a little bit ago. I think one of the metrics that you focused in on early was the left without being seen rate, which tells you more about being able to pull people in and get them through. Historically, where were you compared to where you wanted to be?
Yeah, and left without being seen, you're exactly right. That was kind of one of those true north metrics that we identified. And in my mind, when we looked back at it, I mean, we were honestly not doing well prior to this work. We had days where our left without being seen was 8-10%, which to me as kind of an operational owner at the time, I was vice chair for operations within the emergency department. That to me is 1 in every 10 people that come to get care with us, we're saying, no, we can't take care of you, right? And that's just not acceptable for an emergency department where people, are coming seeking care, many of whom, really in their mind are truly having an emergency, whether the ultimate diagnosis is or is not. There's a reason they came there to seek care. So that's where we started. We realized just from a business perspective as well as a patient experience perspective, if we see that we can consistently drive that number down, we targeted less than 2%, just given where we had started, and now even further down. That to us was one of the true indicators that we had really changed something and be able to provide the service that we intend to provide.
Well, you said something very interesting in the last answer that I think would resonate with the IT audience and the clinical audience that's probably watching us right now. And the word was constant tweaking. And it's kind of a little bit of a setup in the sense that, you and I have been doing this a long time, 20 plus years of doing emergency medicine. I remember doing it on paper. I've been through 3 or 4 electronic health records, and none of them, no matter which one you have, and I know you have a great one, are really good at the constant tweaking part, at least to respond quickly to the constant tweaking. Was that a barrier that you found? Or was that something that early worked, but as you got more advanced, you needed something different?
Yeah, I also during this time was actually taking on a role within informatics as an associate chief medical informatics officer. And to me, there was always the thought, that eventually we had to be able to make these tools sustainable. We started like everywhere with kind of paper and pencil in terms of tracking our performance. And then we realized, boy, we really need this to be something that's more available to the teams, on a consistent basis. And I banged my head against a wall for a period of about 2 years trying to figure out how to get our EHR to really support that workflow. And I came to the realization after a lot of work and thinking around it, is just not the nature of the design as it is to have this kind of really team-based focus that presents real-time metrics that the team can really look at on a area by area basis, nor were the metrics we were looking at necessarily the metrics that we were able to design toward. So that's what led us kind of away into a new area of thinking. How can we actually digitalize this in a more effective way so it really helps the teams outside the EMR?
Yeah, absolutely. So you did the journey, you did the lean process, you came up with some ideas. This next slide that you're flashing up really talks about some of that. You just wanted to spend a minute talking about the 2 or 3 key concepts that came out of there that you then wanted to operationalize in an electronic system.
Yeah, so I think this will make sense when you look at the tools themselves as well. Is that we designed our whole design concept was around flow cells, lean flow cells. And really, those are just, autonomous teams working together, in an individual area around a certain kind of type of patients. Probably the easiest way to think about it in the emergency department is a patient that comes in, is relatively low acuity. We should be sending that patient to a different flow cell, to a lower acuity flow cell that has different operational metrics and goals around how efficiently we should get that patient through, as opposed to someone that's critically ill, that we know is going to take more time, more workup, more resources. So those are the flow cells we refer to. And then really those flow cells have to all follow the same kind of standard work. They need to pull patients in, on a 1-by-1 cadence. They need to be, you want shift by shift consistency in terms of what the team's doing. So we spend a lot of time developing kind of what is the work of a patient care tech within a low flow cell, right? And that was not work that I was doing. That was our patient care techs that were saying, here's the things, that we got to be able to do on a consistent basis. So you really had that level of understanding. And then you kind of need someone that's able to manage the flow. And in a lot of places, this is the charge nurse. We actually were a pretty large emergency department. We're over 60 beds. So we actually designated a role of a flow nurse that would really help direct flow and make sure that we were meeting those variables and be able to push resources when someone was falling behind or a team was falling behind, to be able to, catch up if we were falling behind goal.
Yeah. Well, it sounds like a very unique and challenging opportunity. So you built this product. You came up with the wireframe concept for it, and then this is, I think, where the Leidos journey is kind of interesting. So I guess I'll share, what I know of how it came together. You were looking for somebody that could take some Lego pieces, give you the flexibility to be able to change in real time. There was connections with what Rush was doing and what Leidos was doing on some other projects. And Leidos, as I said, does a lot of work in the government space around command and control systems. So things like almost every Air Force mission that takes place anywhere in the world is on a platform that's controlled by inputs and outputs that are on a platform controlled by a Leidos. So data coming from satellite data and the refuelers and the targeting systems and command and control, all visualizing it as an example of command and control. And so we took those Lego pieces that we've used for other industries and we said to Rush, what would you like to build? And they said, we want to build this. And I think together our teams, did a really nice job of, maybe I'm biased, of building out the thing that we'll walk through in a couple slides. The nice part about it is it's really flexible. That's the first part. So that if you make a change tomorrow, and I think the COVID example is pretty interesting of how you had something designed and not. The other part that I think is just genius of your design, and I know I've told you this several times, but this audience hasn't heard it. Nowhere in this conversation are you talking about what doctors and nurses should do for the patient, which tends to get a lot of pushback when you say, doctors, you must order this, or the patient has to have this done if they have this complaint, or nurses, you have to do these things if the patient has that. All you're saying in your tool is, doctor, do what you want, but when it happens, we're going to get you to a point where you can measure against that metric. So if you think a chest x-ray is ordered, cool, but then we say when a chest x-ray is ordered in this flow cell, it should take this long and your results should be back at this. So I think that was genius. What do you think?
Thanks, Don. I think a lot of this is funny, and this is where truly, I can't remember if you and I have talked about this before, but this is where we had started, as you described. We started with the relatively what I describe as a bootleg version compared to what we have now. Prior to partnering with Leidos, we had just tried to stand up somewhat of a digital tool, but wasn't as functional, didn't look as great, so that's really where this partnership came together and the agility that we found in the tools with Leidos. But as you described, this is something that I had to message again and again, is this is not trying to dictate the work. This is really trying to set expectations around, here's our goal for when we order and collect a UA to when it should be resulted. And if it's not resulted, we should, there should be a flag so that you're aware and the team's aware that this is something that's falling outside of our agreed, service level agreement. The piece that I can't remember if I told you is this actually came from early in this work, It was during a shift I had that there was, as happens probably, 1,000 times in emergency departments across the country, there was literally a patient that I had ordered a UA and was sent off. And I realized, about an hour and a half after the results seemed like it should have been back, I was like, what the heck, caught up in the midst of other things. I was like, how did I, and I asked my friend and nurse said, did you see this as back? She's like, oh my gosh, what the heck happened to that? Right. But there's no shared visibility into that.
Right.
And it's only because, I eventually went looking and said, why can't we, why can't we continue to advance care on this patient? So that's sometimes where these things came from, right? It's from that real-time experience saying we can't let silly operational things like that. It shouldn't be dependent on the physician, the nurse, the lab tech, anyone on the team to be staring at the HR to see when, result goes from 0-1 to 1-1, right? It should be clear. There should be kind of operational guidelines, and the system should be very easily telling us if something's falling off kilter or falling outside that agreement.
Yeah, I agree. And I think I agree. You said it earlier. The easiest way to talk about it is just do some visualization. So we have a few slides in the last 15 minutes or so showing you the visualizations. And then I think the results slide really is telling of what has come from this. And then we'll maybe wrap with what's next. So I'm going to flash up the first slide or the next slide of the tool, perhaps. And this, I think you call your and-on board. Tell me a little bit about just looking at it, what you see.
Yeah, so I think I'm sure the audience is probably familiar with kind of the and-on concept within Lean, but it's just like it described really, how do you tell when things are on track versus off track, right? And how do you make it easy for teams to know that things that we're performing on goal or that we've fallen behind goal? And these goals are all established by the teams. This is an open conversation, laying out what's the work, what's the acuity, what's, the reasonable expectation to get this in. So you're looking at our entire department here, and what you can look at, and this is again the customizability of this, is I can look just at my area, or if I'm in the role of a charge nurse in this case, I can quickly at a glance tell, for each given flow cell that's represented there on the left-hand side, I can tell what the constraint is, right? What's on track, green, what's off track, and then even what's the recommendation, right? So if one looks to the bottom of this screen, just as an example, and we look at that high resource flex flow cell that we built, we see that 3 arrived in the last hour, there's 6 waiting, and we're behind goal in terms of the length of stay within that. And then there's a recommendation to pull, that we should be on a cadence to pull the next patient back. And again, you can see on the right-hand side of that, that same row that we have 5 of 12 rooms open, and the last patient was roomed in 37B. So that tells me, that team, that nurse in charge of that room, we don't want to put 2 patients in a row because we know that's going to help, he or she to fall behind. So it again, at a glance, I'm able to tell exactly within each flow cell and within each area of the ED where I'm falling behind or where I'm on goal. And I think that's really the purpose of this tool.
Yeah, and then I hit the button fast. This you call your pitch board, right? And so this is where you get into the details of the individual workflow like we talked about. So the doctor has seen the patient, they've put in their orders, and then they go about seeing the next patient. And this is really that tool that pulls in that individual data. Would that be correct?
100%. You're exactly right. This is really where, again, if I'm working within a flow cell, I can see at a glance what's fallen behind, right? So, if I look at the low resource flow cell, I see there's 1 waiting. We have 9 people that are in process in a capacity of 10, but the 2 patients that rise to the top are someone that's reached goal in room C10, that I can see that I'm 3 minutes overdue in terms of what the goal length of stay was for that patient. So that's probably someone I got to think about disposition. And then there's another patient in B9 that there's labs or imaging that's fallen outside of the goal. So there's a result that's fallen behind. So I think, for those of us that stare at EHRs all day and these long lists, this makes it very easy, not just to see performance of the flow cell that I'm in or the area I'm working in, but also who's falling behind and who's not, as opposed to a much more complex array.
Yeah, at an individual patient level. And I think the genius is if you look at the mobile version on the right, the check mark of the doctor ordered it, so what? Where are we in that journey? Where are we getting hung up so that you can intervene on that part? And It's measured in minutes, which again, in the concept of measuring healthcare in minutes is something they do in all sorts of other industries, but healthcare, it was different. Lean started to get us to think that that was okay, but here's where you're actually operationalizing it, which I just think is a great move. The last slide that we have on sort of the tool is sort of the flow conductor, if you will, the board of the flow. Tell me what I'm looking at.
Yeah, so we were very intentional as we looked at each tool. It wasn't necessarily just building tools for tools' sake, right? And the design principle we always thought was, well, who's the audience for this, right? And you have different audiences for each type of tool, but this one was really targeted for that flow nurse or charge nurse role. And again, everything needs to be at a glance, right? It should be easy to look up and say, shoot, here's where the area that I got to go respond to. I got to kind of go to Gemba and understand what's going on, specifically with that patient. So this, again, obviously there's the orientation. Anyone that works within our department looks at this and immediately recognizes the different areas within it. But I can see quickly that I got to go see what's going on in room 17B, room 19B, to really understand why I've fallen so far behind goal on those rooms. But then also I'm able to see how the other areas are performing against goal, right? And where we're on track, off track. So where do I need to bring resources? As a charge nurse, this is the area where our charge nurses don't have patient assignments, but this is really their assignment, is to go and get things back on track anywhere that it's starting to pop as red.
Excellent. And so how much data do your people have to put into this system? Do they actually have to type anything?
Yeah, no, that's the beauty of it. This is all pulling, this is all integrated. So there is no data that's entered. There's no extra, go check this box to say it. It's all flowing seamlessly through the data that's in the EHR. So really their only interaction with it is really to know where we are against goal. They're not having to input anything on their end.
Excellent. So you did all this, you operationalized it with some tools. I think this next slide is going to show us some results. So I got your luck without being seen results slide. I don't know if you knew that was coming, but here it is.
There it is. No, and this brings back always PTSD, like the days spent like looking at these numbers. And as I mentioned, even if we went back even further, there were days or even days within this that it was as high as 10%, averaged out when we look at it on a month-to-month basis, up 4.5%, 5%. So this is the piece I talked about earlier. If 1 in every 20 people that walk in the door into an ED that's a volume of 200, there's a number of people that came to seek care that you simply couldn't get to, which is unacceptable within an emergency department. So you had it, and then you started your process on paper and pen, right? So that's what we're seeing. That's it. So this was the early iteration, and this is what it was one of those things I remember. Almost within a week, we said, geez, we did something right. We introduced a number of these tools, and all of a sudden, things seemed to change like almost, within a week. And I really was holding my breath and wanted to make sure the data I was getting was right and go down and make sure things looked as good as they did, because the volumes had held pretty consistent. But we all of a sudden we're reaching target, and reaching targets more than just getting to those individuals, for those that have their business hat on. That for our chief financial officer and chief operating officer at the time, that's additional patient visits, which of course is,
I think you said 1,700 or something. That's a lot of extra patients a year that we're leaving that now are being taken care of, let alone 100%. The financial return.
That's it. That's exactly it.
And then I think this next step was where you said, yeah, it was cool. We played whack-a-mole though. We started focusing on it. Then we started other things. Then there's staffing challenges. Then there's inpatient capacity flow challenges. And it sneaks back up.
That was it. Yeah. So we hit a period where we started seeing this little bit of slippage, away. And it was also during this period that we were actually short. We were having to shut down some. We had some capacity constraints on the inpatient side that we had to shut down. So that resulted in some more boarding. And then our ED staffing was actually a challenge. So, I never expected that we were going to be able to take our eye off this and it was just going to continue to flow in perpetuity. But this is actually where we started engaging around with Leidos around, we need better tools and we need better design and we need more accessibility to actually really be able to bring these new tools to bear. So we started in about January 2020.
Then look at this, look what happened. It was so perfect.
I don't know what happened back in March 2020, but Yeah, all of a sudden, right? All of a sudden we had, COVID hit us and we were trending down in the right direction. And then suddenly this was down, but not necessarily volumes were down too, right? People were afraid of coming to the emergency department for good reasons. And we were taking care of a number of COVID patients. So, I was really eager to see as we emerge from COVID, what results would look like, because that would tell us, are these new tools really working? So this was in control. But I'm happy to say that, as we emerged out of COVID as well, further into 2021, as the peaks had gone down, you see that in spite of high volumes, we were back to the same volumes we had seen back, a year or two prior. But we had far better control over left without being seen, which to me really was an indicator. Okay, this is working. This is more the operational platform and the tools that we have the teams using seem to be sustaining.
Well, I know we'll try to get some chat question and answer if we can, but what's next? You have all these Lego pieces. What do you want to focus on next in the last few minutes we have?
Yeah, I think one of the interesting things, and you and I talked a little bit about it early on, is in we're moving hopefully toward post-pandemic world, right? And what we're already seeing, as things are a little better controlled, is there's this return of really high acuity volume, and that leads to challenges itself. I think a number of departments across the country are probably struggling again with some staffing challenges, or they're staffing with they're challenged with boarding, things like that. The way that this happened, it's somewhat serendipitous, but the fact we have these tools in place that seem to be keeping a lot of those, again, the things we can't control as directly, it seems to be keeping check on those, and people are in this operational cadence. I think it's helped our teams, and even with this return of really high acuity volume, our teams are doing well with this, which to me is a great relief, because we've all just been through a horrific couple of years in terms of I'm hoping there's only one pandemic we work through in a career, global pandemic. But
I agree. I agree completely. It's not been a fun 18 to 24 months. I would agree completely. And I know the COVID was a good example. I set it up earlier, so I'll just tell people, you were in the midst of COVID. You had this perfect design system. We had said, here's how your flow cells look. The board was there. COVID happened. You had to redesign your emergency department, like literally overnight, like everybody else did. And the tool, I guess it's not really a question, I'll just describe. The tool was able to change overnight to match those new flow cells and that new work, which is the beauty of having, I think, something that is as flexible as you need to really get the near real time, within seconds or minutes, the results you're looking for, instead of the death that we suffer as emergency department leaders. As I got something that happened last Tuesday, and now I have to go talk to somebody about, and I can't do anything about it. Hey, last question with the time we have left. What if I wanted it? Is there something, if my health system wanted to get this tool, is that something Rush is interested in sharing?
Yeah, 100%. I mean, this is something, again, that designed for this was really intended that, if we can show that operationally the impact this has, it's something that we should be able, to offer out to others. And it was kind of from that standpoint that we really designed so that it didn't just work for the Rush Emergency Department, but that it worked globally for emergency department and even beyond that in design. So certainly happy to reach out and talk to anyone if it's of help, to talk through some of the details on what we did with the tools, how we implemented, how we oriented, all those pieces.
Well, I want to thank everyone for joining us this afternoon for this session. If you have questions, feel free to reach out to the meeting organizer. They will certainly get questions to Dr. Casey and I. Thank you once again. Have a good afternoon.
Thanks.